Thank you, Sean. Thanks everyone for coming. Welcome. So I do have the honor of facilitating this panel today on healthcare innovation. Healthcare, I think, will focus mostly a little bit on global health as opposed to US healthcare, but happy to take questions and see where the conversation takes us. So as Sean mentioned, I'm with the Bill and Melinda Gates Foundation, based actually out in Seattle. And the Gates Foundation is guided by the belief that all people everywhere and that that all lives everywhere have equal value, and that our mission is to help all people live healthy and productive lives. I'm with our global programs team, global health and our global development programs, and in those programs we focus on developing countries and improving people's health, well-being, giving them a chance to lift themselves out of poverty. And innovation is essential to that. The name attached to our foundation tends to be synonymous with innovation, certainly in the technology sector. And so we're big believers in the importance of investing in and supporting and taking to scale innovation that can help improve people's lives around the world. I'm currently with our development policy and finance team, which looks mostly at the money side of the issues, but spent the last few years working with our vaccine access program. Big believers in the opportunity that vaccines provide to help children everywhere have a healthy start to life, and have been spent about the past decade working on advocacy and communications for health innovation, new health technologies. So I'm really excited to be here with Leslie, with Mark, to talk about the work that they're doing, hopefully answer some of your questions. So I'm going to introduce Leslie very quickly and then ask her to talk about Jhpiego's work, because she'll do much more justice to it than I will. But Leslie has over 25 years of experience in developing public and private partnerships around health development. She spent 14 years as Jhpiego's president and CEO, and before that was 13 years with Project Hope as their president, as their COO and then acting CEO. She's asked me to keep the bio short, so I won't name the many boards she sits on and awards she's received, except to note that under her leadership, Jhpiego did receive the 2014 Classy Award for Health, so very relevant to this conversation. So Leslie, why don't you tell me a little bit and tell our guests here a little bit about the work that Jhpiego is doing on health innovation.
Thank you so much. Well, for those of you that don't know, can you all hear me? Okay. For those of you that don't know Jhpiego, as he said, we're an international nonprofit affiliated with Johns Hopkins University, and we've worked to ensure that where women and families live does not determine if they live. So for over 43 years, we've worked in more than 155 countries, side by side with governments and local organizations and NGOs and partners to help the country build its own capacity to provide quality family-centered care. We work in areas like maternal child health, family planning, HIV/AIDS, TB, cervical cancer prevention, and many other areas, always focused on making sure people have access to care no matter where they live, from household to hospital, from the community, certainly to the city. A lot of our work certainly is around access, and one of the areas that's been a pillar of our work has been working with innovations, developing low-cost, effective, efficient innovations that provide access to health care for people that oftentimes don't have access to health care. And this dates back, way back in our history. We look at innovations in different categories. We have process innovations, we have device innovations, and we have technological innovations, but always focused on the demand and the market and what's happening in those settings. And we'll be talking about innovations later. So certainly we feel by having our staff, the 90% of my staff working in the 50 countries around the world are in the countries and from the countries. And so having them in the roles they are allows us to understand the communities, understand the countries, and thereby develop innovations that meet the needs of those countries. That's all I'll say.
Thanks, Leslie.
Thank you.
Now to introduce Mark real quick, CEO of Possible. Mark formerly worked with a Nepali social entrepreneur on ways to treat malnutrition in Nepal, has created multiple businesses in Nepal focused on healthcare and nutrition. You have been working in Nepal, it seems like, for almost half dozen years, a bit country focused, but maybe you can tell us a little bit about Possible and the work that you've been doing to build healthcare innovation in Nepal.
Sure. Thanks, Brad. We're at a very different sort of stage of our organizational life cycle than Jhpiego, much earlier in our time, but similar perspective on how to approach healthcare issues around the world. So we're a nonprofit healthcare company that's working to build a high-quality, low-cost model for the world's poor. We've started that work in Nepal, where we've been working since 2008. And as we think about innovation, the subject of this conversation, I think we really think about innovation on two sides of the healthcare equation. One, how you pay for healthcare, and two, how you deliver healthcare. And what we've done is we've really realized that, unfortunately, healthcare systems around the world are very broken, even in the US here. And the sort of nasty thing about how that works is healthcare works the least for the people who need it the most. And what we've realized in Nepal is that there are very, very strong constitutional mandates to deliver on the right to healthcare. Many countries across the developing world actually have very progressive constitutions that say there should be free care provided to the poorest citizens, but governments have a hard time operationalizing that, to realize that right for patients in the country. So what we've figured out is, and still figuring out, is a way to work with government in a public-private partnership model to deliver comprehensive healthcare. So we can talk more about the model in a bit, but what that means is we deliver care across sort of from the hospital to the home. So we work at hospitals, clinics, and with community health workers in very difficult regions of rural Nepal. And we expanded after the earthquakes that struck the country about 14 months ago, and I can talk about that expansion a bit later and what that's meant for our vision of trying to scale up this model in Nepal and inform a similar model in other countries around the world.
So I want to take a step back a bit and talk a bit about the need for innovation. Now, both of you referenced, Leslie, you say that where people live shouldn't determine if they live. Mark, that the system often works the least for the people who need it the most. Some people might say that it's so we should focus on fixing the current system, make what we know works work, as opposed to trying to come up with new ways of doing things, new innovations that are out there. And so the need for innovation pops up again and again. I mean, I've been working in health innovation for a decade and keep hearing the same questions again. Why do we need new ways of doing things? Now, Leslie, you work in particular, Jhpiego works in particular on maternal and child health.
Right.
So where do you see the importance of innovation, particularly in that space?
Sure. Well, I think, when you look at global health, oftentimes one can looking at innovations as being from like minds and creating new ideas from like minds in global health. The challenge with maternal child health, is it's extremely complex. Thus, that's why, although we've made progress, there are still many geographic locations that have really stagnated when it came to the mortality of women and children. And so we tend to look at innovations around bringing together unlike minds for maternal child health, bringing together people that aren't always thinking alike, and creating solutions for the things that are still killing women and children that don't need to be. And so again, this could be a process innovation, this could be a technology, it could be a device. Let me give you just a process, and it's an older example, but I think it warrants what needed to happen. There's a drug called misoprostol that when given to a woman can stop her bleeding. But the biggest challenge is that it was not designed for what it could be used for. It was designed actually originally as ulcer medicine, but we had to show, we knew that the number one reason women are dying in the world is they're dying because they're bleeding to death. And we had to show that there could be a way to use that medicine in a safe way in a community, train a community health worker that would train a mother and be able to use that medicine in the correct way. Now, I won't go through all this story, but I will say to you that it has gone from bringing together all these minds to figure out can you in fact teach a mother to take the medicine at the right time after she delivers a baby? Can you in fact train a community health worker? Would this still encourage that family to go to the facility if they could, because we know that will save a mother's life? And most importantly, would it save those women's lives? And all I'll say about that process innovation is that in fact, We have scaled it up in places like Afghanistan, where the access to facilities for women are very remote and very far out. And, you know, it could be 6 hours before they could get to a facility. We've scaled it up in Nepal. We've scaled it up in South Sudan. So it's gone from an idea and a concept to WHO. And let me just say, Jhpiego works with partners. So anything I say is in collaboration with the countries, the local governments, international NGOs. It's with many, many groups involved, and so many donors. But let's just say that that's an example where we had to get all these different minds together to figure out for one concrete problem, one need, how we could do something and look at cost. Was it affordable? Look at the conditions. It doesn't need refrigeration. Look at all the issues one would look at when you're creating what I would call a process innovation.
Yeah, no, and I'm glad you mentioned process innovation, because I think that innovation can often be seen as a buzzword for a new vaccine, a new drug, a new diagnostic, some drone that can drop blood serum into the remotest parts of the world. But it's the systems themselves that often need the most innovation. And Mark, you've spoken about the need for a really innovative, comprehensive healthcare system, particularly in the poorest regions. Otherwise, we can't get any of these technologies to anyone. So what are you guys doing in Nepal in order to support that system? Yeah,
when I think of innovation, I really think about innovation in terms of the design of the healthcare system itself. Is it designed to get high quality, low cost care to the poorest, most marginalized patients in a community? And I actually kind of use this road and cars analogy when I talk about innovation. I think we are all sort of enamored, and we see a lot of headlines and news articles and demos and all sorts of things with these sort of product innovations. And if you think about roads and cars, these product innovations, the great newest way to dispense a medicine, or the new thing you can put in the hand of a community health worker so she can do a diagnostic better, those are sort of the product side of innovation, and those are sort of the cars in this analogy. But what I see from my experience in global health is that we don't have the roads to put those cars on. And so there's a real traffic jam going on in the world where there's an innovation delivery gap. I actually think we, in some respects, not all respects, in some domains, we have more innovations than can be delivered. And certainly in the communities we work in, we see that there are people dying from things that we've had innovative solutions for a century. I mean, and so I really come at innovation from this perspective of we need a lot more highway builders. We need good, high quality, highly effective organizations that are operating health systems so that we can get these wonderful innovations to patients. And I think in many ways, I think about our role in the world as kind of being like the Kaiser Permanente of the world's poor, right? We need to be a big, reliable, nonprofit healthcare provider that puts our patients first so that we can partner with product innovations and make sure they get to our patients. And this is already being done. You don't have to amass scale and then innovate. You can innovate on your path to scale. So one of the innovations that we've thought about from healthcare system design perspective is actually an electronic health record. So it's probably a very common reality for many people in the Western world or in the US to have some sort of interface with an electronic health system. In Nepal, it's non-existent, and it's not as simple as just finding a product that works in one hospital that allows you to get better patient data so you can report that out to your donors. The real health system design innovation is, can you work to build an electronic health record that syncs seamlessly with the government's existing reporting system so that outside of us, outside of Possible as one organization, this could be picked up by a community of partners, by a community of healthcare facilities, and scaled across the country, right? That's the kind of innovation that we're thinking about as we're growing our own on-the-ground footprint. Can we build sort of these products that are part of our model, that are designed for scale within government systems?
Yeah, so government systems is a key point there, because in a lot of developing countries, particularly in the poorest communities, government is delivering healthcare. Government, not always synonymous with innovation. Leslie, maybe ask you a little bit, to talk a little bit about the work that Jhpiego has done in terms of the partnerships you are building with governments, other public or private institutions to try and drive delivery of innovation, particularly partners, perhaps like government, that aren't necessarily the fastest moving partners in the world.
Well, I'll talk about, we have a lot of innovations, but let me talk about the device side. There's 3 innovations. I won't talk about each, that I could talk about today. One is the Ebola suit that I will go into. The second is the CryoPop, which is a new device to be used for treating of cervical cancer after you screen using vinegar, which I can talk about. And the other is what we call an e-partogram, which is a smart device that'll track labor and delivery using a smart device instead of all the paper that midwives use. But let's talk about the Ebola suit, because I think that's interesting from many partners. So you have Ebola going on, and we have staff already working in Liberia and Guinea in maternal child health. And you see all the groups that are going in to provide service and do their different focus areas, their different missions. And when we got our staff on the phone, they said, you want to help with Ebola, look at helping the health workers. Just so you know, about 881 health workers were affected by Ebola, and 513 died from Ebola during that crisis, probably more numbers than that. And so we began working with, again, it goes by the demand, it goes by the need, it goes about thinking about cost, it goes about thinking about can you scale it up, it goes about thinking about that pathway that one takes to do this. And so we got their ideas and said, well, what's wrong with the Ebola suit? And they said, it's too hot. It's really, really hot. And when you're working in an African country, we have to take it off every 2 hours. It takes 22 steps to get the garment off. And it was seen that that was probably the time that the health workers were getting contaminated. There's no visual field in the headpiece. If there's a visual field, is very small. And so there were many, many areas that they contributed. We began working with the School of Engineering. We work with a center there in the School of Engineering that works with us on global, low-cost, frugal innovations. And we did what we called the meeting of unlike minds, and we brought people together from all across the campus, from every school, as well as some a person that was a wedding designer and others that wanted to come together over a 3-day weekend and think about how to create a new suit. The long story short is that the winning one was submitted for a competition with the US government. We were one of 5 groups that won the challenge. And as a result of that, and in the midst of that, GE Foundation and governments, of course, we were working with the Guinea government and the Liberian government. Everyone kind of came together to look at this. It's now at a step with the grant we got. It allowed us to work to find a company. DuPont has now taken it on. This garment has gone through already a screening in Liberia and Guinea with the governments behind it. And now the next step is a new usability and a screen that CDC and others are going to be doing to look at the garment. But it really took the governments, the local groups, nurses, doctors, public health experts, engineers, all coming together, coming at it from a very different way, but creating a solution that we hope will be a low-cost solution that is going to be usable. The new suit takes 5 steps to take off. It has a very large visual field on the headpiece and many others. We're still looking at the heat component, but there's many, many other variables in this. But there is no way a Jhpiego would have created that if we didn't have the support of all these different groups that came together and thought differently about how you go about designing this. The wedding designer alone created a way to sew it in the beginning that created some of the ideas. I mean, it was just, it allowed us to do something that hadn't been done. And when you talk to some companies that have been in this business of these garments, they said, we didn't think of this. They came to meet with us and said, here, we've been working in this field for years, and we didn't think of this. But it was this collection of people coming together that made this innovation, we hope, where it is today. And that's just one example of what we're dealing with.
Oh, that's great. And Mark, in Nepal, as you know, I studied abroad in Nepal in college, dear to my heart. Very challenging environment to work in, very resource poor country. Had a lot of political challenges over the years. How have you been able to partner with the government or other stakeholders there to make sure that you can bring those kind of unlike minds together and do the work that you want to do in country?
Yeah, I think it begins with a certain kind of mentality around innovation, and what I would say is that mentality has to be that you have to embrace constraints as your friend. And I think the road to scaled innovations is littered with failed efforts, and those efforts are failed usually for two reasons: that they didn't take the end user into question, they didn't design the thing based on who it was benefiting, and they had unlimited resources. And so I actually think the difficulty of an underfunded government provides a constraint that's really useful. I think you have to frame it that way or you would sort of be demoralized by the challenge. So in our case in Nepal, we're designing our whole operation for the government to be the majority payer over time. And so we know at the onset what the government can theoretically afford to pay, and it's in the range of $20 to $25 per capita. By contrast, we're spending about $9,000 to $10,000 per capita in the US healthcare system. So we have a very real financial constraint. And when we work with our government partners, that's front and center in a lot of respects, because we know we don't have unlimited resources to do whatever we want. So that forces conversations that need to happen. And one of the conversations that it forced was this notion of, if we do only have 20 bucks as a government to spend on healthcare, how can we spend that most efficiently? And so we were at the forefront of working with government, partnering with them to roll out a performance-based funding system in the country. It's still very early, it's in its nascent stages, but that's an example of where constraints force a particular financial model that actually makes a lot of sense. Because if you're spending $20 to $25, you don't want to waste $1 or $2 somewhere in the system. And so paying for outcomes rather than paying for procedures and stuff is sort of a surefire way to make sure your money gets spent well. Now, that's incredibly complex to do with the government. It's going to take a long time to make sure it's operating extremely efficiently and at the level we want. But I do think that's just a great example of where being really rooted in reality about your constraints and embracing constraints as your friend in innovation is key to get the job done in settings like this.
And you used a phrase when we were prepping for the panel about creating access without excess.
Yeah.
Can you say a little bit more about the excess side? Why does that worry you? I mean, we obviously want efficiency. We want use innovation in a cost-effective way. It's great to find ways to do it as cheaply and efficiently as possible, frugal innovation. But what's so bad about going in the other way and having a little excess in the system as well?
Sure. I think as an American, I can start with sort of our mentality around healthcare here. I think we have two things that create a very negative or vicious cycle with respect to healthcare. One, we have a more is better mindset, and two, we basically have a fee-for-service healthcare system to a certain extent. And as a result, we want the best, we want it all, we want everything, and it costs a lot of money. And so, the dangers around having a healthcare system that incentivizes excess or doesn't constrain excesses are sort of twofold. One is patient harm. I think if you have a physician or a clinician in front of a patient and they have a financial incentive to give a patient something they don't need, oftentimes they're going to do it. And we've seen wonderful people be compelled by that incentive. And if you were a poor clinician living on the edge in a marginalized community, you might do the same thing. I think it's a very, very hard incentive to overcome. And so that's one thing. And so if you're giving patients things they don't need, you are introducing potential medical harm into the system. If you get a bunch of x-rays you don't need, it actually does bodily harm. And the second thing is, if you're using a fee-for-service model, you're actually potentially driving patients into poverty through the very act of paying for healthcare, which is, of course, is something that I believe should be a basic fundamental right. And so around the world, we know, and Jim Kim, the president of the World Bank, spoke about this at the World Health Assembly a few years ago. He said they know from their data that 100 million people around the world have been pushed into extreme poverty, paying out of pocket for healthcare. I mean, how ridiculous is that? as a system of healthcare, a thing that should be a right, a thing that should be a platform allowing people to escape poverty, right, to allow them to be productive in their educational lives and their economic lives, is actually the thing that's sending 100 million people into extreme poverty every year, and there's 150 million additional that go into financial hardship. So, you know, I think we really think hard about not just the access side, but this excess side, and we want to make sure that the incentives that we have, the constraints that we're working with, don't force this issue of excess, because we've just seen a tremendous amount of waste and harm for our patients.
Yeah. And of course, at the end of the day, any innovations that we introduce in the system that work, we want to be able to take to scale. Right. That requires financing, that requires efficiency, that requires impact. You know, Leslie, Jhpiego has programs all over the world. You're testing innovations of all shapes and sizes. There's a term I hear a lot about, pilotitis. You know, you can pilot every innovation in the world, but if you can't take the good ones to scale, then what's the point? So what are you doing, and where have you seen successes and maybe failures in this in Jhpiego's work, in taking the things that you are finding work and actually being able to roll them out in a way that impacts as many people as possible?
Well, I think first you step back to, when you're thinking about innovations, you should be thinking right up front with that idea is the possibilities for scale up. Like, I think when when we're designing things, we're looking at questions to make sure we decide on what we work with. And if we don't believe that it is scalable and that there are barriers that we can't overcome, and we know this by the staff we have that are on the ground, the nurses, the doctors, the midwives, the public health experts that are able to translate that and say, this isn't even going to be real even if we could. And you know, when we started out, we developed a process innovation and a device innovation. The process was screening for cervical cancer at a time that no one really cared about it. And I would say that Gates actually was in the forefront of helping a few of NGOs out there that were looking at this issue when no one was looking at the numbers of women. 1 woman every 2 minutes dies of cervical cancer in the world still. And we started with a process innovation that said, you know, we needed to come up with something other than the pap smear. If you take a country like Thailand, they had the pap smear for 20 years and only 5% of women ever got it. They didn't have the labs, they didn't have the health workers. There's many things involved in this. You know, the excess comment also relates to what health workers you have available, who's there. And so we designed a program that was looking at science and evidence around the use of vinegar that could be used to screen for atypical cells for cervical cancer. It's low cost. You can find it in any market. We designed the program alongside, like I said, other NGOs that were talking about it. We ourselves were focused on working with nurses and midwives, believing there weren't OBGYNs in countries, and figuring out how we could we train nurses and midwives to not only screen, but to treat using a freezing device. Now, the freezing device we knew was going to be around $1,000 to $1,500, but still low cost if you compare it to any pap smear, having a lab, having, you know, again, in the time we started this, you wouldn't be able to find women even if they came in for screening to tell them the results. So women could come and get screened and treated all in the same visit. What we're creating now as a result of 22 countries that have been moving this along and scaling it up is we're creating a device that's more durable, more portable, lower cost, that will be able to be utilized in all parts of the country as the device to use for freezing. Obviously, the challenge always is to get a company interested, a private sector interested in the low-income countries. The reality of frugal innovations is we do oftentimes struggle with the valley of death, you know, where you've created something to a prototype, but you can't get it out there because you can't get someone to invest in something because it has a social benefit, but it doesn't have a profit benefit. And so obviously that's what we're working on now with many different groups, but obviously we've seen We hope that this will be brought to scale using the cryopop now. We've certainly brought the program to scale in certain countries as it is now. And I see governments like Ethiopian government. I was just there with the First Lady, and they've invested in all these cryotherapy units. So I know the scale up will continue. But there are many countries that can't afford that. And so we were looking at what next. But I think, scale up, everyone here, as we're thinking about new ideas, new processes, you need to be thinking about what are going to be the barriers to bringing this out. We don't even think in pilots anymore because it is not appropriate for any countries to be getting pilots at this stage. If we're working it, we've got to look at how you are able to get by those barriers and be able to get this owned by the country. Now, let me just say regarding cost, the single visit approach in Thailand, we brought it under the health system of the government. The Thai insurance system, which is this, I won't get into it, pays for this type of screening. So the finance side of it is covered as well. And so you have to look at all that if you're going to do innovations, I think, responsibly for low-income countries.
Yeah. So before we go to questions, the one other thing that you have to be able to tolerate for innovation is failure and risk.
Yes.
And I am lucky enough to work for a funding institution that has a relatively high tolerance for risk. I think that's why we've been able to do a lot of the good that we have been able to do. And so I'm curious to hear from each of you about a failure you've had on the road to innovation and what you think that's taught you, that's helped make your work better. And maybe Mark, starting with you.
Yeah.
We've all had.
We certainly believe in risk as well. We just have a little bit less of a backstop in case that failure happens. So we get a little nervous sometimes, but no, I think it is a real challenge as a decision maker in an organization to say, we want to take this bold risk, and we're going to have to sort of go fall on our face in front of key funding partners if it doesn't work out. But I think it's required, and I actually think the funding community's more so than ever very accepting to that idea. So I think organizations who aren't taking risks are probably not going to grow. And so we've had a lot of failures. We really have sort of a fail forward mentality, right? This idea of continuous improvement, just brutal honesty with ourselves. And so I think we actually published an academic paper not that long ago, a few weeks back, with our partners, former partners at Medic Mobile, about like a community health worker mobile phone initiative that we tried to launch with them. And there wasn't blame on either side of the partnership. That wasn't the purpose of the paper. The purpose of the paper is to just highlight how even the most well-intentioned, thought out innovations, even if they are tested by users, et cetera, there's still a fairly high degree that failure can happen because of all sorts of external changes in the environment. So in that case, we really got started on this before there was a dialogue about having a national electronic health record in the country. That dialogue picks up. We realized that actually we just need a different product in the hands of our community health workers that can feed back information to the electronic health record. So it was actually just a technology barrier in a lot of ways. And there wasn't a workaround except to build a different product and use the constraints and the mindset of scale that we have to get it adopted over time in the national health system. So that's one of many. The good fortune about still being relatively small, we have 260 full-time, over 400 full-time, part-time team members on the ground in Nepal, is that cost of failure still isn't too high. I have a lot of admiration for Leslie and her team and how thoughtful they are about not viewing things as a pilot because the cost of failure when you're working at that scale can be quite tremendous, and it can change the mindsets of some of the key partners that you're working with if you overpromise and underdeliver. So I think one of my personal lessons as a young leader and leading an organization in this kind of uncertain environment is that actually you do want to underpromise, overdeliver, and not the other way around, because the people you're serving, their lives depend on your success, and you don't want to create false promises.
Leslie?
Well, without question. We all have failures. First, risk is inherent. You must take risks in leadership and in innovation. It is inherent in it. I say to my team all the time, leap and a net will be there. And I say that because I want to instill in them a notion that risk is we're trying to save women and families' lives. And we're trying to do that with evidence-based ideas that, flow, and we have to take risks to do that. And so we were working on a preeclampsia test, and we had gotten very far along. Preeclampsia is the number 2 reason women die in the world due to pregnancy-related causes. And we were doing this test to be able to test as women. It would be, in the United States, you go in and you get a urine sample and there's, things to being done. But we want to do a test that could be done in the communities. Again, where women access a lot of their care, don't have access to a hospital or a facility. And we got very far along. We actually won an award to work on it. We were working with the engineering school. The reagents were in a little pen device. We had processed it all the way until the point that everyone came together, the engineers, public health, the midwives, the doctors, and said, due to the circumstances of the heat, due to the circumstances of the lighting, we just could not get it to a point that it would work. And I think, at first it was bringing the team together and recognizing that people had put a lot of time into this. It did create awareness, I will tell you, around the world about preeclampsia being a big issue that we need to continue to address. But, that's part of what we're doing is we have to take those risks. We created an awareness. We tried to figure out what could be done in a remote area. It didn't work, but we learned from that. You learn different skills from those things, and we move on. And I think if you create in your organization a culture that a well thought out decision making and risk taking is important, if that's what your organization wants to be doing, I think if you want to be a dynamic organization, risk is part of it. It's figuring out how much you want to tolerate, but it happens.
Yeah. It does. So now I would love to throw it open to the audience here and any folks online who want to ask any questions. Anyone at all?
With so many refugees and so few dollars available, we have to understand that when people move, their pathogens move with them. What are some of the solutions we need to be putting in place to detect expected and unexpected infectious diseases?
Who wants to take that one?
That's an interesting one.
Yeah.
I'm not the expert on infectious disease. I think what we have to recognize is whether there are refugees moving or not. The global world is a global world now, and infectious disease is all part of everything. We should be looking at that whether there's refugees or not refugees. People are traveling more now than ever. And so I think what we have to be looking at is the systems we have. A lot of the work we're doing right now is around just simple infection prevention strategies, basic hand washing, basic systems. When there is no soap, what do you create? But I do think, like I said, I'm not the expert on infectious disease as it is. I would argue that the world is global and we need to be acknowledging in anything we're looking at that what happens in one country can easily be brought to another country, and are those countries prepared? As Ebola was taking place, what we did was 2 things. Obviously, working on the Ebola suit, and I didn't tell you why, all the maternal child health clinics shut down in most of those countries because no one would take care of the women because of the blood. And so we were trying to get them open, but the health workers wouldn't come unless they thought about protection and knew about hand washing. We then realized you have all these countries that border those countries that really didn't know what to do. So we used our own money and invested and worked with governments and brought together health workers from the ministry from 18 countries in the region to learn about infection prevention and how to don a suit, the suit they had at the time, and how to take it off. And so we did a lot of that, and that was really because we knew people were going to be traveling, and there would be circumstances where people would go into a country, and that's going to happen in the United States, and we just have to know that we're prepared.
Yeah, I'll offer a couple quick thoughts as a non-expert in migration and refugees also, but I will say one of the many wake-up calls with Ebola was that, a small community in West Africa with a broken healthcare system can potentially create global catastrophic risk. And that's true every day. That's always been true since we started flying in airplanes. I mean, since more people started flying in airplanes and more people started migrating and for reasons around refugee status, it's probably increased, it's probably picked up a little bit. But I think from my vantage point, one of the things that I would talk about as a part of the solution, there's no magic bullet, right? There's no panacea, but a part of the solution is having strong base of community health workers in every one of these countries. I think the Ebola was as damaging as it was, and it wasn't nearly as damaging as it could have been, but it was as damaging as it was because there wasn't an efficient mechanism for early detection, surveillance, and finding those who had come into contact. Right, so that contact mapping. And in order to do that, you need personnel. You need people who understand village communities, who know the way people interact, et cetera. And the only people I think who are, well, I'll say the people who are most qualified for that job in the world are community health workers, who are often women living and working in these communities. And one of the things we really believe in is that those should be dignified, professionalized, paid jobs in every country around the world. And I think until you have that sort of ground game in place, you have paid, professionalized community health workers, we are at risk of infectious disease spiraling out of control because there's lack of early detection and surveillance.
Yeah, the only other thing I would add is, as someone who comes out of the advocacy world, is that what a lot of this needs is just sustained attention, commitment, and resources. And that's very, very difficult. I mean, we say that Zika's a wake-up call. 2 years ago, we had a wake-up call with Ebola. We still had Zika. When there was a gentleman who flew to the United States bringing an extremely drug-resistant form of tuberculosis to the States almost 10 years ago now, we said that was a wake-up call. We still had Ebola, we still had Zika. It's an organization that works on polio eradication. We've been saying for years that polio anywhere is polio everywhere. We're still very, very close, but we're still working on it. So you need to somehow maintain the momentum, maintain the attention, the focus, and the resources, which is very, very challenging, because there's so many competing priorities and there's so many risks out there. But the most I think that we can all do, aside from come up with new approaches, new innovation, is to keep people talking about it and to keep people focused on the risk. Other questions? Yes.
I had a question about innovating healthcare technologies. And I'm kind of interested in this concept of neighbors helping neighbors along with healthcare technologies. So whenever you introduce a new technology or you innovate something new, it's sort of a way of thinking about the technology that comes with it. I was wondering, in your experience, have you found, like if you're working in a rural area, for example, and you're introducing a new technology or new equipment, what's the best way to ensure that it's adopted and it's not frowned upon, or the fear of using something new? How do you overcome that barrier?
Sure. Well, I could say that, going back, our team is oftentimes from the country, majority of the time is from the country. So if we're introducing something in Tanzania, let's just give that as an example. First, you're working with the government. It's their country, it's their program. So whether that government you're working with centrally and or decentralized, if it's a decentralized government, you're also heavily working with that decentralized. So you're meeting with them, you're meeting with the local organizations, you're meeting with, many times we're meeting with the traditional healers, we're meeting with the community at large. You have to find out who is part of that community, what's happening in that community. So if it's a local traditional group, if it's a religious group, if it's a local NGOs, all of those are part of the players of education. Part of it is education as to why this is something, why it's at this stage, why there's an evidence base that's out there that approves this being used, and what it will do. I mean, we did this with male circumcision. Many of you may know, when the studies came out that circumcising men would decrease HIV/AIDS by 60% in them, and in the long term certainly decrease it in women, the big challenge was convincing communities who traditionally did not circumcise, and then building the skill set of the health workers to be able to do that in those remote areas, not doing it in the cities, but out in the communities. And so in order to do that, all that I just told you went into that. We had to meet with the traditional healers. We had to meet with the religious groups. We had to meet with the NGOs. The government had to know the evidence. It's their country. They had to understand the evidence and understand that they were introducing that and want to introduce that. And so for us, it's all about getting those, we call it the stakeholder group, getting everyone together, teaching them, explaining, showing the evidence, getting them involved. It's not us doing. Again, Jhpiego doesn't do the work, it's them doing the work. It's their building their capabilities, looking at their new innovation. So it's making this owned by them and the change owned by them for their own people. And now, again, in communities that adamantly were against this are now by numbers, in unbelievable numbers in Tanzania, are almost getting to saturation points. And so, but like I said, one has to understand this isn't quick. This is a slow process. It's a respectful process. It has evidence behind it. It is working and understanding that culture right from the beginning. It is knowing you want scale up and not a little pilot. There's many variables that go into this. And I think, I would say that sometimes just that timing factor has been what frustrates people, because they don't want to take the time to understand and know that country and know that community and understand why there are barriers and move through those barriers. They want to leapfrog in, and that's just not, we don't feel that's the best way for a country then to own the innovation and not for us to own it.
Mark, you want to add anything?
I agree with all that. I'll just add a little bit to this to say I think it's a really hard problem to solve, and I think solving this sort of adoption problem it requires bringing forward a mindset of both an anthropologist and technologist. You sound like you're very interested in technology, so you're probably familiar with the notion of the minimal viable product, and the lean startup methodology. And I think you can kind of bring that mindset into this work. There's no reason you can't. I actually think it's appropriate a lot of times, and I think it's very helpful. And so the thing I would say is, we've had a great partnership with IDEO.org, and they do human-centered design, so they really think in this way. They think about rapid prototyping, MVPs, and in addition to everything Leslie said, which I agree with, all of the community work aligning with national goals, when you're there on the ground, I think what you want to be focused on is how can we do this without technology first and test the concept. Like, if you have a mobile phone app you want to develop, run through it on paper. Find the cheapest, fastest way to learn. Because when you're trying to innovate and you want that innovation to be appropriate and actually adopted, what you're trying to do is just minimize the time to try things. So it takes a lot of time and a lot of money to put together engineers and build an app and then do a first test with your user. I mean, that's a terrible way to approach it, right? So you can get 90% of the way there with a pen and piece of paper and sketches. And I think that's been one of the lessons that's come out with our work with IDEO.org, is just minimize the time to try things. And then once you know you've got something that people will use that's going to be accepted by the traditional healers or the mother group, whatever the community is, then hire your engineers, right? But even then, hire one and make a really simple product. And I will say, like, you have to bring a software mindset to this work. We wouldn't be on stage with the biggest private funder of global health in the world if Bill Gates didn't keep iterating on the Microsoft products. I mean, it wasn't like he launched one and expected it to be stable and work and please all of the customers of Microsoft for even 6 months or a year. It's a constantly updated product based on what your patients are telling you in our case, or our community health workers are telling you.
Did you want to add something?
I was just going to mention, one of the things we did, and I don't know if there's any engineers in the audience, is that we brought graduate engineering students from the university to our program sites. We've brought them each summer. We bring 15. And I must say, having them live out in the communities with midwives and nurses and, and public health experts, and get a feel for the barriers that exist before they start thinking about what they're going to do. Because what we then do is we pose them a challenge. We say to them at a certain point in their schooling, here's the gaps we see based on our feedback, here's the problems, and then they decide if they want to pick any of those from Jhpiego. And it's been very eye-opening, and each year they say we need to send another 15, because what they come back and go is, I would have used batteries, but then I found you can't get batteries out there. Boy, does it rain. It rains all the time. Whatever I discover has to be waterproof. And so they come back with a very different vision about issues around water and electricity and cost and environment and culture than they would have just going to school as engineers. And that also has brought together the engineers and our nurses and the midwives and doctors kind of thinking in very different ways about what we needed to do.
You have time for any more questions? Well, maybe we ask them both, and we'll see if we can get an answers to both.
Okay, great. Hi, my name is Melanie Avery. I have a background in engineering and economics, running a nonprofit for homeless veterans and veteran families, and I served in the Guard. When I was in the Guard, we took a trip to Jamaica. We visited some hospitals, and it's a developing country. They did not have soap in a lot of the places where people were performing their medical work, and even in the offices. And we asked them about that. They did not have soap, and they said they did not have hand sanitizer, and they said they encouraged hand washing, but they didn't have soap. But they also didn't have a major problem with bacteria and infection in this hospital. So I was just wondering if you could comment on that. And then secondly, wondering if your work is also focused on individualized healthcare, like looking at genetics and genomics. I know it's incredibly expensive, but are there cheap, fast ways to educate people on what they should be doing with their lives, with the lives of their children, even in these developing nations, so that, as their generations grow, that they'll change their behavior so they can avoid diseases like cancer or be doing things to ward off the onset of those diseases.
And maybe we'll take the second question, and then we'll answer as much as we can.
I'm Marianne Boyle, and I'm with the Global Smile Foundation. A group was in desperate need of advice on scaling up and hopefully developing partnerships. They have what I think is an innovative approach to doing the cleft palate repair in developing countries. They start out with developing contacts in the country to get everybody on board with what they're doing. Then they go in and they start educating local healthcare providers on how to perform these procedures, and then follow up once the missions get underway and then take off. So they're really incorporating the whole community. Then they're doing the missions and bringing people in. Everybody goes back every year to follow up. Right now they're in 9 countries throughout South America, Central America, Middle East, Africa. But it's all volunteer. Am I doing this wrong? They're all volunteer. There's no one, one person who's paid to, coordinate travel arrangements. So it's hard to really get to the next step. And it's really a fantastic process. What we think is innovative. It's comprehensive care, nutrition, speech therapists, oral health, dentists. And I don't know how to help them to take that next step and to get the support that they need to continue.
So maybe on that score, just what are sorry about that, everybody. Is everybody awake now? maybe on that score, just some helpful pointers or advice sort of from other organizations of what might be some productive ideas for taking that next step for them.
Yeah, and I don't know, Leslie, if you want to maybe take on the first one, which is a bit more about some of those systems approaches. And Mark, you seem like the perfect person to talk about startups and to going to scale.
I can take the second one.
Number one, we put out something many, many years ago that's still being used. It's called Infection Prevention Manual for Low Resource Countries. And in it, we actually teach, and you can get it on our site. In it, we actually teach how you make that solution with products from the community that are affordable. So long before we had these bottles of stuff that we cleaned, if you look back, when I came 14 years ago, we were teaching countries how to make those solutions that, in fact, didn't have soap available. I will also say, though, that we've worked, somebody's making drum roll. I would also say that we've worked in countries like Uganda and many countries around infection prevention. We've worked with the government around the importance of having soap or having a cleanser and showed them the statistics, the C-section rates, the infection rates from C-sections and all that. So there's a lot of work that's been done on this, and if you want to, I certainly have people that work heavily in the infection prevention area, and because anything we do, we believe infection prevention has to be part of it. Whether it's working in HIV/AIDS or working in maternal child health, infection prevention is part of everything we work with. For community health workers, for nurses, midwives, you wouldn't go anywhere without that as part of what we do. But I'd be happy to talk to you about that.
Great. And to the second question, I'll start at a fairly high level and just say, sorry, I don't know which level of the organization you're at, but it was a great question, and it's one a lot of organizations struggle with. And so I'd say probably I can be most useful by introducing a framework that I've borrowed from someone else. We have a great funding partner called the Mulago Foundation, and there's someone there, Kevin Starr, who writes a lot for the Stanford Social Innovation Review, and he's written a piece about this, so I can send it your way. But he talks about how you have to imagine yourself at scale. And you can really ask yourself a pretty simple question. At scale, let's say if that's 1 million people treated a year, or 10 million people treated, or 100 countries, whatever your definition is, who is the doer and who is the payer, right? And so it sounds like that would be a great conversation to have in your organization at this stage. And you may be surprised by the outcome of that conversation. It may be consistently doing more of what you're doing now, and you really can develop a way to get big and to get scale through that. Or you may understand that actually we're one player of many. What we're going to try to do is franchise this and support others to get to other countries, or we may try to find a market mechanism or a government mechanism to scale this up. But I think one of the bigger questions in all volunteer organizations is, can we do this at scale if volunteers are the doers versus local healthcare workers or some other player that's actually implementing the action. So I apologize, I don't know about the details. I'd be happy to speak to you about it further, but I think, in the boardroom or at the executive team level, I think that's the question you have to be asking at that stage of an organization, which is, okay, we've made it this far, we're happy with our impact, but is this the same model that's going to take us to point B? And I would just ask yourself, who's the doer and who's the payer at scale?
Great.
All right. Thank you, everybody. Big round of applause for our panelists today. Thank you for an excellent discussion. We really appreciate your time and the conversation.